Welcome, everyone. My name is Jess Lucero, and I'm an associate professor of social work here at Utah State University. And I'm also the co-chair of the CHAS Anti-Oppression Committee. In solidarity with nationwide efforts to support Black lives, we're hosting a virtual teach-in for racial justice here at USU, and that's co-sponsored by the Center for Intersectional Gender Studies and Research in the Latinx Cultural Center and our committee. Our event is taking place on the second day of nationwide scholar strike, and that's inspired by professional athletes' protests against systemic racism. We hope that at USU, this teach-in can connect national conversations to our own academic and local communities in the struggle for racial justice. I am beyond thrilled to introduce you all to one of my USU colleagues, Dr. Guadalupe Marquez-Velarde. Dr. Marquez-Velarde is an assistant professor of sociology at USU. She has a focus on intersectional population health. Her research focuses on health inequalities among Black Latinx communities, immigrants, and the LGBTQ+ community as well. Guadalupe, take it away.
Perfect. Can you see my screen? Can you see the PowerPoint?
Yes.
Perfect. So hi, my name is Guadalupe Marquez-Velarde, and this is the Teaching for Racial Justice at USU. And today I'm going to be talking about police brutality and COVID-19. So how is police brutality connected to COVID-19, particularly among Black Americans? Racial health disparities and police brutality are both manifestations of systemic racism. Systemic racism is the way the US society is organized around complex, interconnected, and interdependent social networks, organizations, and institutions that routinely embed racial oppression, meaning that non-whites are at a constant disadvantage relative to whites in many ways. So how are they connected? Let's begin to talk about COVID-19. People of color are experiencing a disproportionate burden of COVID-19 cases and deaths relative to their population size, which is a racial health disparity. From the beginning of the pandemic, we've seen reports about the disproportionate burden of COVID-19 in Black, Latino, and Indigenous populations in the US. Excess incidence, prevalence, or mortality relative to a group's proportion of the population, it's a health disparity. And these disparities occur due to social disadvantage, which results in differences that are unjust, preventable, and avoidable.
Guadalupe, I think some of your slides are a little bit smaller, at least on the display. I'm not sure if there's a way to enlarge that on the display setting.
Give me a second. Is that better?
Yeah, that's great. Mm-hmm.
Perfect. So as we can see, all ethnic and racial groups in the US, with the exception of Asian Americans, have a higher death toll from COVID-19 compared to non-Hispanic whites. If people of color had died at the same rate as white Americans, about 19,000 Black and 8,000 Latino people would still be alive as of mid-August. All ethnic and racial groups, including Pacific Islanders, Latino, Indigenous, and Black people, are about 3 times more likely, or more than 3 times more likely, to have died of COVID-19. So why do we have these disparities in COVID-19? Minoritized populations have high rates of comorbidities associated with COVID-19's worst outcomes, including hospitalization and death. And as we can see in the graph, most of the hospitalizations for COVID-19, about a third of patients had cardiovascular disease, over half had hypertension, about 40% had a metabolic disease like diabetes, and almost half were obese. So people of color are also more likely to have one of these conditions. But why? These are what we call racial health disparities, and they have persisted over time. They excess their most chronic illness, functional limitation and disability, as well as life expectancy and mortality. Since the late 1800s, scholars like W.E.B. Du Bois have argued that the higher levels of poor health among Black Americans were an indicator of racial inequality in social advancement and living conditions. Fast forward to 2020, and most racial and ethnic groups have higher rates of disease than whites, excluding Asian Americans. Racial health disparities are the byproduct of racism at the macro and micro level. Racism is a threat to good health, safety, and well-being. One of the most evident forms of institutional discrimination is residential segregation. Residential segregation is shaped by local and federal de facto policies, and it limits access to a high-quality education and employment opportunities. It concentrates poverty and social disadvantage, and Black Americans continue to be the most segregated racial group. Every American city has residential segregation to some degree. Of course, as diversity increases, so does segregation. So we can see that in Chicago, Washington, D.C., and Houston, you have clearly demarcated areas where different racial and ethnic groups live. Segregated neighborhoods face many health risks and threats. Poverty, the lack of economic opportunity, means that people of color are more likely to be working jobs that are currently deemed as essential during the pandemic. Poverty at the community level yields high exposure to chronic stress and hardship. These neighborhoods also are food deserts. They lack supermarkets, so there's no access to nutritious and affordable food. There is poor infrastructure and institutional neglect. This comes in the form of poor quality housing, lack of sidewalks, parks, or other safe areas of recreation. There's also environmental injustice. There's an increased exposure to toxins, poor quality air and water, among other health hazards. And lastly, there's low wealth accumulation due to the low property values. All of these conditions hinder the ability of people to have optimal health and are chronic stressors. When we map COVID-19 on residential segregation patterns, we can see in these maps of Milwaukee and Chicago that as the proportion of Black people increases in the neighborhood, meaning it is segregated, the COVID-19 infection rate and death rate also increase. We have also discrimination at the individual level. Discrimination at the individual level is also a chronic stressor. It is not only the event, the racist event that is stressful, but also the anticipation that you would be the target of racism. It is associated with an increased risk of both physical and mental illness, and it also affects how much healthcare people use. But how does racism get under the skin? Our bodies are not meant to be chronically stressed, and racism is stressful. If we are exposed to adverse circumstances over a long period of time, it triggers a physiological response in our body that wears and tears our physiological systems. And we call this the allostatic load. The allostatic load is measured by biomarkers of substances that the body releases in the presence of stress, like norepinephrine, epinephrine, and cortisol. And also, it is measured by the long-term effects of high stress situations, such as blood pressure, high cholesterol, high levels of blood glucose, and these effects are not explained by poverty. So when we look at the population, we see that a higher allostatic load, meaning people have been exposed to chronic stress, they are more prone or they are associated with chronic disease, premature death, and worse overall health. And the effects of chronic stress in the body affect every single body system, from the brain to your reproductive health. Police brutality is a major stressor. In 2017, there were 1,147 deaths by police. Only in 13 cases, police officers were charged with a crime. That is 1.1% of the cases. Police killings are the 6th leading cause of death among men ages 25 to 29. It is a leading cause of death for Black men in America, and Black men in America already have the poorest life expectancy and quality of life relative to men in other racial or ethnic groups. Police brutality is a major manifestation of racism, and we know racism leads to poor health, which means it makes you more susceptible to the worst outcomes of COVID. Police brutality then is a social determinant of health. First of all, it has a physiological response. As I just explained, police brutality is a chronic stressor that has an adverse physiological response, not only in your physical health, but also your mental health. Police brutality usually results in fatal injuries. So victims of police brutality are usually result in the killing of people. Black people also have to deal with racist public reactions that exacerbate the issue. Things like justifying the killing or having to explain to people why Black Lives Matter, or even perceiving an underwhelming response from the community can take a toll in terms of health. And there's also disempowerment and the hyper-awareness of oppressive structures, which might leave people with a sense of hopelessness and that there's really nothing that they can do to change the situation. The normalization of violence against Black people and Black Lives Matter supporters is becoming normalized. This violence has a negative ripple effect in the health of entire communities, particularly among Black Americans. Headlines, videos, social media postings make it easier to access this information, but also it's a constant reminder of systemic racism and how dangerous it is for Black men to encounter police. Awareness of police brutality affects the mental health and social development of Black boys and young men. Residents of neighborhoods with high rates of stop and frisk policies are more likely to be in poor health. Police brutality also increases mistrust in other institutions, including medical institutions, which is particularly relevant during a pandemic. And we don't have any reliable data on police killings, only on police killed. No reliable data means that we do not have enough data to allow for better accountability and to study or to research the negative effects of police brutality at the community level. So racism in its many manifestations takes a heavy toll on people of color, particularly Black Americans. Racism puts people of color at higher risk of chronic illness, which means higher risk of COVID-19 infection, hospitalization, and death. Police brutality is also a manifestation of systemic racism and a social determinant of health. The disproportionate numbers of people of color who have died of COVID-19 and those whose lives were cut short by police violence died because of systemic racism. All these deaths were unjust, avoidable, and preventable. Thank you.
Thank you so much, Guadalupe. Thank you for helping us connect those dots between police brutality, racism, and health. And thank you for sharing your expertise during our teach-in today. We appreciate your time.
Thank you.